The learning objective is going to be understanding risk factors for thrombosis and the role of inflammation, including the biomarker high-sensitivity C-reactive protein, which I'll refer to as CRP, and how to modify risk factors or reduce or eliminate their impact. I'll begin the theme that's going to be continued the rest of this afternoon session on heart-healthy living, and I'll speak about medication adherence. It's important to understand that we can lump together all of the major thrombotic diseases: acute coronary syndrome, which includes myocardial infarction, stroke, pulmonary embolism, and DVT, because they all share common risk factors: cigarette smoking, diabetes, hypertension, hyperlipidemia, which is high cholesterol, prior history of a vascular event, a family history of thrombosis, and genetics that predispose to thrombosis. And I want to bring up that inflammation is a root cause of many of these thrombotic complications. Inflammation begets thrombosis, and then thrombosis begets more inflammation, and a vicious cycle ensues. And I'll come back to this theme over and over again to explain the role of aspirin as therapy for some of these thrombotic diseases, and to touch on the role of the statin drugs, not so much their lowering cholesterol, but to understand that the statin drugs also play a major role in reducing inflammation. Let's give some examples of inflammatory triggers that lead to DVT and pulmonary embolism. Having an infection such as pneumonia will increase the likelihood of a DVT by about 3-fold. Getting a blood transfusion because of the preservatives in the blood transfusion will also more than double the risk of a DVT or pulmonary embolism. And receiving an injection of a drug that specifically helps stimulate the formation of new red blood cells causes an inflammatory state associated with an elevation in DVT or pulmonary risk 9-fold above average. And here are some examples of risk factors that are actually in and of themselves inflammatory states. So if you have any of these risk factors, you can be sure that your own level of inflammation is increased above normal, thereby predisposing you to acute coronary syndrome, venous thromboembolism, or stroke. And they include overweight, or the metabolic syndrome, which we can think of as a pre-diabetes condition, or diabetes. Now, there are two crucial questions that we can ask and answer in terms of inflammation and its relation to thrombosis. Are individuals with elevated levels of inflammatory biomarkers, such as CRP, at high vascular risk, even if they don't have any other risk factors whatsoever? And the answer to this question is clearly yes. And do individuals identified at increased risk due to inflammation benefit from a therapy they otherwise would not have received? And the answer to this is clearly yes. Let's drill down into this, a meta-analysis of 54 prospective cohort studies looking at the CRP concentration, that measure of inflammation, in terms of developing coronary heart disease or dying from a vascular cause of death. And what you see is as the level of CRP increases, as shown on the x-axis, the rate of developing coronary heart disease and heart attack increases on the y-axis. As the rate of CRP increases on the x-axis, the likelihood of dying from vascular cardiovascular disease increases on the y-axis. When we break down the relative contribution of CRP compared with a high blood pressure or an elevated cholesterol level, we find that CRP has the greatest contribution to increasing the risk of vascular death or the risk of developing a heart attack compared with the other known coronary risk factors. This study comes from the Physicians' Health Study. These were originally healthy physicians, 20,000 of them, who volunteered either to take aspirin or its placebo for 10 years. And at the beginning of the study, they had their blood drawn and CRP levels were subsequently measured. And what you see in the background in the blue bar are the CRP levels in quartiles. So the higher the CRP level, the higher the risk of their developing heart attack over the course of time. These patients, half of these physicians were randomized to receive low-dose aspirin. And what you see here is that in the group of physicians receiving aspirin, the higher the CRP level, yes, the heart attack rate went up a little bit, but not very much compared to the placebo group. So this is a clear-cut example from the Physicians' Health Study showing that aspirin's anti-inflammatory effect protects against cardiovascular events. Let's switch from heart attack to DVT and pulmonary embolism. 2 trials were just published in the New England Journal using low-dose aspirin versus placebo in patients who had already received 6 to 12 months of anticoagulation for DVT or pulmonary embolism. And at that point, they and their doctors were uncertain whether additional anticoagulation would be worthwhile. And they were put into this study where the anticoagulation was stopped, and they were randomized to receive either low-dose aspirin or placebo. One study called Aspirin from Australia, and the other study called Warfasa from Italy. And when we pool the results of these 2 studies, we see that that aspirin was better, and there was a 32% reduction in new onset recurrent DVT or pulmonary embolism in the patients who received low-dose aspirin rather than placebo. And again, this shows us what we can do, the power of anti-inflammatory therapy in thrombotic diseases. Let's take another study. This is an 18,000 patient study of patients who start off healthy. The only problem all 18,000 patients have is that their CRP levels are elevated. They have a high inflammatory state, but they are without any symptoms whatsoever. They were randomized to receive the statin drug rosuvastatin, which is also known as Crestor, or they received a placebo for rosuvastatin, and they were followed over time for up to 4 years to determine whether they would develop a symptomatic DVT or a symptomatic pulmonary embolism. Remember, they're not taking aspirin. They're not taking any anticoagulant whatsoever. The only condition that these patients have, these 18,000 individuals, is that they have silent but elevated levels of CRP, that marker of inflammation. And what we see with rosuvastatin, which has the most anti-inflammatory effect of all the statin drugs, is that there was a 43% reduction in DVT or pulmonary embolism in this trial called the Jupiter trial. The message I'd like to get across is that most risk factors for thrombosis are modifiable. Cigarette smoking, hypertension, the lipid profile. We and our clinicians taking care of us have the means of modifying and changing, eliminating or reducing these risk factors, and all of these are risk factors for more inflammation. Overweight, metabolic syndrome, and diabetes, again, these are risk factors that increase the level of inflammation, yet with nutritional strategies and with medication and with specialty consultation, we can reduce or modify these risk factors for thrombosis. Now, medications are part of the solution. It's not just lifestyle alone. So I think there are some important questions to be asking our clinicians taking care of us. First, am I taking the medications I've been prescribed in the dose and the time intervals given to me? So we have to get clear-cut instructions from our clinician as to what drug we're prescribed, how often we should take it, and in what dose we should take it. The second question, do I understand the rationale for each of the medications being prescribed? Let's say we're prescribed a statin drug. Well, that has two different effects. It lowers the cholesterol, but our physician might be giving it to us primarily to lower the level of inflammation. And then we need to know if we're on an anticoagulant, is my anticoagulant a novel oral anticoagulant or is it warfarin? C. Everett Koop, Surgeon General of the United States in the 1980s, made the very pertinent observation that drugs don't work in patients who don't take them. And there is a new push from the Surgeon General's office called Script Your Future, and it brings out some very sobering statistics. First, 1 out of 3 people never fill their prescriptions. Well, now we send our prescriptions electronically to the retail pharmacy or to the mail order, but that doesn't mean if they're sent to the retail pharmacy, the patient might not go to the pharmacy to pick up the prescription. Second, nearly 45% of the population has one or more chronic conditions that require medication. Third, nearly 3 out of every 4 Americans don't take their medications as directed. And finally, more than 1/3 of the medication-related hospital admissions are linked to poor adherence. And these are sobering statistics. They have consequences because there are unnecessary deaths and unnecessary disability due to failure to adhere. And there's a cost estimated at $290 billion per year for this disconnect between what's prescribed on one hand and what's actually taken on the other. To conclude, common risk factors predispose to heart attack, stroke, pulmonary embolism, and DVT. Inflammation is a contributing cause to most thrombotic illnesses, and overweight and diabetes are examples of chronic inflammatory states. Heart-healthy lifestyles work in conjunction with medications to minimize the risk of thrombotic diseases, and nutrition and exercise, and we'll be hearing much more about this the rest of the afternoon, underpin the heart-healthy lifestyle. Finally, medication adherence is of paramount importance. Thank you very much.
Thank you, Sam. Thank you very much. Now, I get to ask Sam like 50 questions a day, so you ask him questions, because I get that every day.
I was just wondering, when you have something like pneumonia that you mentioned, how long is your increased risk?
Sure. So the question is, when you have pneumonia, how long does that inflammatory state persist? And it really persists out for at least several months after the pneumonia. And that's why when we track patients who develop DVT or pulmonary embolism after a medical illness like pneumonia, they might be fine the first couple of weeks, but if we track them, there's a continued uptick in the DVT or pulmonary embolism rate for at least 45 to 60 days, maybe even longer.
Yes, sir.
My name is Sam Stivers. I'm interested in the issue of inflammation and CRP that you talked about. I've been dealing with DVT for about 10 years. To the best of my knowledge, I've never actually had a CRP test. It strikes me as strange that either my primary care physician or a cardiologist hasn't been tracking that relative to inflammation and considering treating it for inflammation. Is that not something that I should be asking about?
Right. Well, I think that points to the issue that we've tried. There's been a tendency to split and separate the thrombotic illnesses. So CRP is standard operating procedure for coronary disease and coronary heart disease risk. What I'm bringing to the program this afternoon is to alert you that this separation of coronary heart disease from DVT, from pulmonary embolism, from stroke is pretty artificial, and that we can begin to assume that a pathophysiology that plays a major role in heart attack, such as CRP, also plays a major role in stroke, in DVT, and in pulmonary embolism. So this is sort of new information that's being disseminated now.
But I should start tracking that, sounds like. Is that not
Well,
correct?
CRP is an important risk factor, and I think the best example of this, the epitome really, is the Jupiter trial, where the rosuvastatin, which we think of as a lipid-lowering medication, in these patients, they had normal cholesterol levels. It was given solely to reduce their inflammation as measured by the CRP level, when in the group, in the 9,000 who received rosuvastatin, whose CRP level went down, their rate of developing new DVT and new pulmonary embolism decreased as well.
Thank you.
Yes, my name is Richard Elam. My mother raised the issue of the use of aspirin together with warfarin as it related to blood clots. And I'm a little bit confused because it seems that you seem to encourage the use of both to prevent further blood clots, and the other doctor was saying that it was sort of not recommended for the other issue. So how do you reconcile those?
Right. So I think Dr. Ruff was talking about stroke prevention in atrial fibrillation,
right.
And it turns out that the anticoagulants can, to some extent, reduce the risk of inflammation. And I think what we get concerned about when we hear someone's on both warfarin and aspirin is that unless they have multiple thrombotic diseases, such as heart attack plus deep vein thrombosis or heart attack plus pulmonary embolism, that aspirin can add to the bleeding risk when it's combined with a potent blood thinner.
Thank you. I had a personal question myself.
Yes.
When I was meeting with you in your office, you
Yes.
mentioned that fish oil and I believe it was
Vitamin
E
Yes.
were things to watch out for.
Yes.
And for me, that's an issue. I work out a lot, and I have
Yes.
a lot of supplements that I take.
Yes.
And one of your people said I was in great condition, but now all of a sudden I can't have vitamin E, and,
Yeah.
I can't have fish oil supplements.
Right. So fish oil and vitamin E exert an anti-platelet effect. And if you're on a full dose anticoagulant, you're at risk of bleeding. And if you add on top of that fish oil or vitamin E, you increase the risk of bleeding even more.
So I have to cut it out completely.
So we recommend, if you're on a blood thinner, unless there is an evidence-based reason, to cut it out completely.
Okay, thank you.
One last question.
Yes. Hi, my name is Nancy Castanelli, and my daughter had a pulmonary embolism at age 22 last January. She had knee surgery, but she has other factors. She has high cholesterol. And I've been trying to help her manage this, and it's been difficult because her INR ranges from 1.5 to up to 3.6. So she's trying to diet and exercise, and she was taking Lipitor, but she had to come off because she had a lot of muscle aches. So with her range going from high to low, she started eating salads, and sometimes she's inconsistent with it, as well as, she's a teenage, well, she's a young adult now at 22, and she tends to like to go out with her friends and drink liquor. So her INI has fluctuated so much, it's like, I get very nervous. It's like, when is it too low that it could be clotting, and when is it too high that you could have internal bleeding or brain bleed? So how long does it have to be at that level to cause that problem, and how do I help her manage that?
Sure. So I have several comments to make. I take care of a lot of teenagers and a lot of patients who are in their 20s. And one thing they tend to have in common is they believe that they are indestructible.
Yes, I agree.
And that belief actually spills over not only into their medication, but into other behaviors as well, which can be high-risk behaviors. And so I think a lot of the therapy, if you want to put it that way, on a big scale, is just sort of stepping back from the specifics a little bit and trying to convince them that they're human also, and that as people they are susceptible as well to all the things that their older people that they know, like people in their 30s, who are really old to them,
Exactly.
Also experience. So, first of all, the heavy drinking, that's a big problem in teenagers and in a lot of people in their 20s, even if there are no medication whatsoever. And it can actually be it's a serious health hazard, and it's one of the major causes of death among teenagers and people in their 20s. Now, take that's someone without any medical conditions. Add to that a blood thinner medication. You're fully anticoagulated. Alcohol is this very potent antiplatelet agent. We say, regardless of whether it's warfarin or whether it's one of the novel oral anticoagulants, at the most, there should be no more than one beer or one glass of wine per day, nothing more. And I don't think we're going to come up with any way to get around that problem. So that's my first major comment. And then the other thing is, she in your presence in your house is sort of in the hospital, is in a very protected environment. A big problem isn't, she's got all the right values and she knows, or the left side of her brain knows right from wrong, but there's tremendous peer pressure. There'll be peer pressure, not only to drink, but it seems that what I usually see is the drink in the left hand, and if they're righty, the cigarette in the right hand. So there's a lot of peer pressure. And remember, the cigarette smoking is also going to be a major cause of an increase in the CRP level. So I think these are the big problems that whether we're physicians, nurses, pharmacists, family members, friends, this is the big project we have to work on. As to her INR being all over the place, she should probably be on one of the 3 FDA-approved novel oral anticoagulants rather than warfarin. As to the muscle pain she's getting from one of the statins, there are 6 statins that are FDA-approved. Generally speaking, if you have muscle pain from one statin, if you just switch to another statin, you can get rid of it.
Okay. Recently, she saw a hematologist, and the hematologist told her that she could drink it, but just moderate drinking. So I think that kind of opened the floodgates that she's thinking, oh, moderate. Well, that could be really as long as I don't get drunk. So that was a little frightening to hear that. So it's good to hear that you're saying one drink, because that's what I was afraid of, how.
No, it's no more than one drink a day. By the way, this is not a problem, alcohol is rampant in our society. This is not a problem that's limited to teenagers or younger patients in their 20s. Patients in their 30s. I have even 5 patients over 100 years old. Alcohol is a problem at all ages and becomes really dangerous. And I ask all my patients, and face to face at close range, looking at them, how much alcohol do you drink? And it's a really important issue, particularly if they're on a blood thinner.
Okay. So if she has her blood taken 1 week and it's like 3.6, how long does she have before it's maybe a brain bleed or it's internal bleeding, so that will cause a problem?
So I don't want to do her medical care plan from here,
okay.
But it sounds like she should be on a novel oral anticoagulant and not be taking warfarin.
Thank you.
The person behind you has been waiting patiently, so one more question and then we'll move on.
Thank you, Dr. Goldhaber, for your information. I really appreciate it. So what do you think about the newer oral anticoagulants for thrombophilias, say antiphospholipid antibodies, factor V, or protein C and S deficiency?
So all the major trials allowed patients into those studies if they had a thrombophilia. The patients didn't have to undergo thrombophilia screening. So in general, I think they're fine.
Okay, and then my second question is, the 2012 CHEST guidelines mentioned warfarin use while women are trying to get pregnant. What do you feel about that?
Warfarin use while trying to get pregnant?
Right.
I think that's okay, but warfarin should not be used beyond week number 6 of pregnancy. And remember, the way we count the time clock for pregnancy, it's when at the beginning of your first menstrual period, that's when the clock starts to tick.
Okay. Thank you very much.
Thank you.